So first we have Allison Matthews, an experienced design lead at the Mayo Clinic who brings perspective from her background in both architecture and medicine to fuel patient experiences that matter. Some of those experiences have been leading the Mayo Clinic's Bold Forward Unbound program in Rochester, Minnesota, as well as being a real driving force in redesigning the Mayo Clinic's primary care experience. We're also joined by Dr. Suhas Gandhi, a resident physician in internal medicine at Brigham and Williams. I'm making my own hospital, Brigham and Women's Hospital. He has many passions, one of which is being committed to using policy and innovation to redesign the American healthcare system. His work on healthcare payment delivery and reform has been published in the New England Journal of Medicine, JAMA, Lancet, anywhere that matters, and his general healthcare perspectives have appeared in CNN, NPR, USA Today, Stat, and Scientific American. Last but not least is Brandy Parker, Senior Design Director of Health at IDEO, the global design and innovation firm. She's a health design and strategy leader coming to us with 15 years of experience in products, services, digital, medical device, patient provider, really robust sphere of lenses. And her background in design, ethnography, psychology, and nutrition all fuel her unique whole person perspective on both medicine and design. With that in mind, I'm going to stop sharing my screen so we can see all of our lovely panelists and kick things off with Allison, who's going to lay our foundation today. Allison, my first question for you is that, in theory, has an experience in service design always mattered in healthcare or should have mattered? What's different about value-based care? Why is it changing things? Is it changing things? And how have you seen that play out in your own work?
Just a tiny little question.
Tiny 8 questions.
No, thank you for throwing it my way. So I think that, of course, design has always been, and kind of really considering the experience of the patient has been something that's been fundamental in healthcare at all times. But value-based care really compels healthcare organizations to reimagine their approach to healthcare and to patient care specifically, and creating a greater emphasis on preventative measures, patient engagement, and holistic well-being. And that really does necessitate a fundamental reevaluation of how we design healthcare experiences. But I think the devil is really in the details, as with any big idea. It's very agreeable on the surface, but the real rocket science is in how you operationalize and incentivize the right type of work. The challenge really is that all of this hinges substantially on behavior change, which is really one of healthcare's biggest challenges. And so it's similar to things like financial planning, where you're trying to get someone to save for maybe their retirement later on. But the challenge in healthcare is you're not always even asking them to do something in terms of their behavior change to make something a whole lot better in the future, but just not make something bad happen or not allow that to happen. So it really is a challenge. And I think we even find in countries like Sweden that some of the most reliable measures, when they're in a fully value-based system, they still are measuring on volume. So how can you even set up the metrics and the incentivizing structures to allow for this? So I think in our work that we're doing right now, we think that the biggest value is being able to design more personalized patient-centric service lines by leveraging what's now just coming on is the huge data and analytics and digital health technologies. So we're moving actually away from personas and toward hyper-personalized journeys that can shift at any moment to kind of meet the patient's need and compel some of this behavior change.
Very, very interesting. Allison, you were mentioning the devil's in the details, and one of those details is the measurements. Brandy, I know you have a lot of thoughts around this. Value-based care requires, if we're saying quality relative to cost makes sense. We all know what dollars are, but quality is a little fuzzier of a word. How are we measuring quality now, and how should we be measuring quality?
Yeah, one of the things that when I think about value-based care, and one of the challenges that I see in the work that I do is, value to who, first of all, right? Like who is this value to? And I think we all know the answer that often it's to the hospital system, right? And so I think quality, the same question can be said of quality for who? What does quality mean within the system. So oftentimes, I think I see hospital systems using that espouse value-based care. They're relying on gatekeeping methods that are measurably reducing costs by actually just by restricting access to what they deem to be unnecessary care. For example, reducing the length of hospital stays, and they are relying on somewhat narrow measures of quality and outcomes. It's a little tricky to measure quality, right? And so oftentimes the measures of quality are like readmission to the hospital, for example. That's one that can be used and can be looked at. And I think that makes sense, and that's great. I think overall, I think it does make sense to measure if people are being readmitted to the hospital. But there are times when I think that doesn't necessarily mean that the patient is having a quality experience. They are having a quality outcome from the perspective of the hospital, and that they didn't come back into the hospital, but are they having a quality experience? And how does that influence then how someone shows up again within the healthcare system and their thoughts and perceptions about that healthcare system itself? So for example, you send the person home to recover early, that maybe that was the right decision. But did the patient understand why they were being sent home from the hospital? Were they and their caregivers set up with what they needed to take care of that person at home? Did anyone think to tell them why they were being sent home, or think to set them up for success when they get home? Does that caregiver now have to take off work to care for their loved one at home and help them recover? And, did anyone think about that except for, a nurse as they were walking out the door? How are we thinking about how the patient is experiencing the care, and how they then engage with the healthcare system after that? Because a lot of patients have experiences like this, and then they're hesitant to go back again, right? And so then we see people that are not showing up in the system, and then they're outside the system. So then we don't really know what their outcomes are. And then we see them show back up then in the emergency room 5 years later, right? Because they then were scared to engage with the system again. So I think we need to find other ways of thinking about what quality means, and what does it mean to not just have a quality outcome from the hospital's perspective, but what does it mean to have a quality experience for the patient within the healthcare system? So that's some of the things that I think about in the work that I do.
If you had a magic wand, what do you think should be the KPIs, the key performance indicators of a quality experience?
I think that depends. I think that really depends on what you're designing and why. And I think that it really is something that needs to be on a case-by-case basis. I think that I still believe in the power of stories, and stories are not necessarily something that can always be measured. But I think that quality and moments of quality, if you ask any nurse or doctor, what's a moment that stands out to you where you felt like you really delivered a quality experience to a patient, they can all tell you stories of what that means. And they can also all tell you stories about what it means to not deliver experiences of quality, and moments where they felt like they really were not in that bucket of quality. And so I think that we can really look to those stories to understand how we can measure quality in the future. And oftentimes it's tricky, right? Because it's tricky. It's not necessarily easy to measure how much a doctor is really listening to their patients rather than dismissing them, for example, and measure that impact over time. But I think we need to try. I think that we need to ask patients and doctors and nurses what those measures of quality are. And then I think that then working over time, we then need to, as design partners, we need to partner with business strategists and data scientists to really learn how they think and teach them how we think, and have them and ask them, how can we think that this is really contributing to patient experience, right? How can we measure this over time? How can we work with you to show you the value of these outcomes? What outcomes would make sense to you? And how can we work backwards from that? Because I think doctors and nurses and patients instinctively know when they've had that experience that matters to them, right? And so I think the the real challenge is measuring that over time. And so I think that if we're able to partner with the people that are decision makers and work backwards from that, and I think that that's one way we can start
I
to
think
measure.
just to add on to that, one thing too, I always say, the best experience at Mayo Clinic, especially because we focus on serious and complex disease, is to never ever have to come. And so there's a real danger in design of equating an excellent experience with healthcare with something like an excellent experience in travel or an excellent experience in other things that they might encounter. And really, the best experience is for the individual to remain healthy, which is what value-based care is all about. And so it becomes especially tricky to measure for that reason.
Mhm.
Suhas, before I switch the angle, from a provider perspective, how should we be measuring quality of patient experience?
Thanks, Karyn, for the invitation, and I love this discussion around posing this question of, are we measuring what matters in value-based care? And I think many of us would posit, speaking kind of from the clinician angle, that we're not. We're measuring things like Brandy mentioned around readmissions and other metrics that are important to the hospital systems where we work at. They may be important because policymakers chose them as metrics that are worth incentivizing around to maybe bring down system-wide costs. But ultimately, so much of what matters in our job and in our line of work is the relationships that we form with our colleagues and with our patients. And it's an incredibly difficult thing to measure, but you know it when you see it. You know it when you really feel it in the room with the patient. This is a patient who you've seen time and again. You understand their situation medically, but also socially. You see them as not just a patient with a recent hip replacement, but as a person who has a job and a family, and I think so much, unfortunately, of what we've done in the value-based care era in the last 10 to 15 years has been proliferate measures that require increased reporting, increased documentation, and other activities that don't always contribute to that relationship, and oftentimes, unfortunately, really detract from it. And so I think this is what the conversation we're having, I think, is absolutely the right one. I think it's hard as I kind of move away from kind of the clinician angle and think about it from sort of the researcher, policymaker, what's sort of right for society. We've also seen that a lot of these value-based care programs actually have not delivered on their promises to either increase quality, regardless of how we're measuring it, or contain costs for the system. And so I think there's I think there's definitely a fundamental sort of rethinking that needs to be done. I do wonder, and I think we do need to think about what are the right metrics and KPIs, but I do wonder that focusing more on those might actually be counterproductive. We know from decades of work in sociology that for tasks that people are intrinsically motivated to do, that they find rewarding, the application of extrinsic monetary incentives can actually crowd out that intrinsic motivation. And so I think there's a lot of things that we need to figure out how to tap into that we're not right now. And I think fundamentally those are professionalism as a field, mastery, the feeling that when we're doing something that we've been trained to do and we're doing it really well, I think is something that's very motivating and gives a lot of joy to our work, and autonomy, something that I think has been eroded from clinicians as a result, I think, of value-based care and increased measurement and increased linking of payment to outcomes. That doesn't mean that fee-for-service is the right answer, but it means that where we've gone, I think, has been a little bit of the wrong direction.
Allison and Brandy, zooming out from the patient's experience and more to other facets Suat was talking about. And a caveat for the whole group, I acknowledge that we're talking a lot about a patient's experience and we don't have a patient included on this panel. Many logistical reasons for that, but we just want to note as we're all making sense of this, that voice is missing. Not on the panelists, on me. But zooming out from the patient experience, Allison, Brandy, how in your work have you seen wins of measuring provider experience, and not just measuring it, but as we think about increasing quality, wins for increasing the quality for provider experience in value-based care, and some areas of opportunity?
I can start, Brandy, if you'd like, and then you can jump in. I think the wins come a lot with what Suhas was saying, and we have done some work where we've begun to measure the patient self-indicated goals and the things that they would like to do, and then our ability to make progress towards them. We're an organization that's largely self-insured, so we have like an incentive to be value-based that way. So we really can kind of say, you know, what is it that what are the goals of the patient who is coming in and how can we support toward them? I was having, though, an interesting conversation with the Karyn Family Foundation about the social determinants of health, which they are advocating are the social dynamics of health, and the idea that all of this gets so medicalized as well. So one of the things that I find most interesting when I spend time with patients, especially in the primary care area, is that a lot of the things that get measured based on value-based systems are things that you're kind of like, why is your doctor in this conversation? Why should they be involved in this at all? This seems a little bit outside of their scope or what you would even want them to do. Of course, they can probably have positive impacts to it if they become involved, but that isn't always exactly what the patient wants. So I think one of the things that is a win is really understanding the patient's story and their goals. But I think a loss is we have not been able yet to moderate where it is appropriate or inappropriate for healthcare to really become a part of the story.
Yeah, that's interesting. When I think about the work that I do, I think that unfortunately, as I've mentioned, I mean, I think that oftentimes measures of quality are not measured. And I think that there, in a lot of instances, we could think about how to measure them, but realistically, they might not be measured within this system. And so a lot of the work that I do is really about less about finding ways to measure quality and more about designing things in collaboration with physicians. And so with anything that we're designing in collaboration with patients, but also in collaboration with providers. And so that process is not a process of measuring quantitatively the quality of what we're designing, but it is a way of gaining input early on in a design process from providers and from patients, because the providers are very easily able to say, this is going to be a problem for me, right? Like, this sounds great for a patient, but this is gonna mean that that patients are asking me 10,000 more questions, and I, and I don't want to be in that position, or, so we're able to then take that input and work it into the designs in a way that then works for both the patient and the provider. So for example, this is an example that's less about the value-based care system in and of itself, and more a product that would live within that system. But we were designing recently a product for a patient that would be measuring something. It's a device that would be inputted into the body, and it would be measuring. I don't want to disclose, it's like confidential, so I can't disclose too much, but it's measuring certain measures within the patient's body, and it's then reporting those measures to the physician so they can essentially know how the patient's doing remotely. So within that, it became very clear immediately when we were initially designing. The physician said, no information should go to the patient. I want it to come straight to me, right? I don't want the patient seeing any information from this. I only want to be able to see that, because I think it's just going to cause too many questions for them. Talking to the patient then says, I absolutely want to know what this device is saying about my body. Like, I want to know that in real time, because I'm worried about my body more than anyone else. So I want to know if something's wrong or if something isn't wrong. And so knowing that those motivations are inherently opposed in some ways, not all the time. I mean, I think that a lot of physicians recognize that value as well, but knowing that those in that moment, those are almost diametrically opposed, how can we design something that actually doesn't cause an alarm for a physician, but gives the patient enough information that the patient feels like they are empowered with that level of information? And so both of those perspectives were then able to inform our design that then let the patient know at a high level how they were doing, or if they're in an emergency situation, but did not give them too much of a high level of information that the doctor would be concerned about getting too many questions from the patient unnecessarily. And so I think really, I guess that's a long way of explaining and using an example to say that I think that designing how the systems work in collaboration with patients and providers is not a way of measuring the quality, but it's a way of ensuring that what you're putting out there into the world is going to work for patients and providers. So I guess I would challenge us all to think about not just ways that we can measure, but ways that we can actively design in collaboration so that even if something is never going to get measured, it still works for everyone.
Brandy, that reminds me of an experiment that we ran here, and we do a lot of experiments that we don't intend to move toward implementation. So they sound rather terrifying. And one of them was that we gave 30 patients the ability to text their provider at any time for a month. And this was terrifying to our providers, but one of them was my husband, so I forced him to do it. And so the idea was patients could text. We had a HIPAA compliant text service, and they could get answers to anything they wanted at any time. We said there are no limits on what you can text about. 100% of the texts were about how to navigate our complex system. And so I think, Brandy, to your point, really digging in to understand the perspectives and not make assumptions about our patients or our providers. And as we shift to a new type of system, to assume that the legacy aspects of the old system will come with is critically important. I know that that's a fundamental tenet of design, but it's easy to forget, because if I just did an interview of a bunch of providers and I said, what would you feel about your patients texting you 24 hours a day for a month? They'd be like, don't even dream about it. But once we tried it, we learned a lot. So that's just an example.
Exactly. And just an example of the power of prototypes as well, to learn more information, right? It's like you learn things that you don't necessarily know that you didn't know, right?
Mm-hmm.
So
absolutely.
Yeah, incredible.
Yeah, no, I love the idea of experimentation, right? And then there's so much you can learn as we, as not only with value-based care, but just generally all the new technologies that are coming that are, a little bit more consumer centric. One theme that I thought of while Brandy was talking is the difference between data and information. And I think there's a push, and I think value-based care contributed to this with proliferation of measures, as well as just sort of, a larger movement that's very well intentioned around patient-centeredness. And some of this is, codified in law through 21st Century Cures Act and, access to EHR data. But data is not necessarily the same thing as information, right? And what we want patients to have is information. We want them to have what is actually relevant to them, whereas so much of the data in medicine, as you all know, is either inaccurate, incomplete, or just irrelevant, right? When we get lab work, we're actually only looking for 2 or 3 of the numbers that we get, but for historical, sort of path dependent reasons, when I want to check a potassium, it's actually cheaper for me to check a full basic metabolic panel that comes with 7 different lab values, of which I'm only really interested in 2 of them. A marker of kidney function and potassium. And so I think ways in which we can design experiences such that it allows patients to have access to information without having access to noise, really, which is what a lot of the data is, I think is critical. And obviously that's sort of the line that Brandy, that you all are towing as you design, and the collaborative design with providers and patients allows you to sort of separate signal from noise.
Very cool. Very cool. We've mentioned a lot of stakeholders that have been around, since doctors are going around house to house. But in value-based care, they are highly incentivized to collaborate at an unprecedented level. Obviously, there's a lot of variability in how that happens if you're talking about just pay for performance versus like full capitation. But across the board, there's more incentive to work both up and down the organization and across different organizations for cohesive patient care. Brenda, you mentioned this a little earlier, but everyone feel free to jump in. How can we champion experience design and just quite frankly get it done in an ever-diversifying accountable system?
Yeah, I don't have an answer to that, but I do feel like it. There's some context I think that's helpful for understanding that challenge, at least for me, which is that even in some of the most innovative clinical settings, I do my outpatient care at Atrius Health, which has been doing value-based care since before the Affordable Care Act, predominantly global budgets, and is known to be a very high functioning primary care system. We still struggle with some of the same kind of status quo workflows that are really entrenched and resistant to change. And I feel change management is I think the part of the secret sauce of redesigning an experience, particularly where you can't start from scratch, right? If you were starting a new clinic, and of course there are many startups in value-based care where they can start with a whiteboard and say this is how we want the experience to be, then that's one thing. But the vast majority of care that's delivered to patients happens in settings where we already are accustomed, both providers, patients, and all of the other staff that we have to collaborate with that you mentioned, Karyn. We have habits, and those habits formed for a reason. And I think it's difficult to re-engineer that experience. And efforts that I've seen to do that have often caused more burden, either in requiring more time, requiring additional tasks on the part of some party that is already kind of overburdened or burnt out. And ultimately increase the cognitive load that we as clinicians increasingly bear. And so those are some of the challenges that I think about with trying to actually, to your point, Karyn, make this happen.
I think the other thing too, so we did a inventory of the different roles in primary care and kind of what they should, quote unquote, take care of, and how we can kind of spread the patient load down the experience spectrum. And I mean like a professional experience spectrum. And one of the things that we found is that, of course, when you think of the doctor in the office, they should be seeing the most serious and most complex patients always. And patients that perhaps need education can go to nursing, or a protocolized care can go through nursing. And you might have a pharmacist come up to do drug interactions, things like that. We found that the thing that I thought that was really interesting was was incredibly threatening to our physicians. And it wasn't because they were worried about the loss of the care that they were providing to their patients to other people. It was for a few things. One was the reason they went into healthcare was not because they just loved solving really complex medical problems. They went into it because they loved forming relationships where they could bring a value to someone else's life. When I stop all of their return visits where we're checking back in to see how the plan went, because a nurse can do that. They can say, like, you're following the plan, you're not following the plan, let's modify it. They were saying, I'm losing the ability to understand the impact that I've had downstream. So that was lost. The other thing they said is it's really hard to see someone who is struggling with a very complex medical condition over and over again throughout the day. And so part of the way that the volume-based system was incentivized is that they could kind of have easier patients during the day. And that was looked down upon when we first moved to value-based care. And so it started to be referenced as padding their calendar, but in reality, that wasn't what they were doing. They were still providing a tremendous amount of value to patients. So we've had to wrestle with how do you still allow our most expensive resource to engage in a valuable way to our system, but then also for them to have professional engagement so that they are loving their job. They're able to really flex their skills. One of the things I think is interesting from one of our surgeons, he said, I deal with some of the most, complex, say, stomach conditions in the entire world, but I can do that because I look at normal stomachs, 29 days out of the month, and I only see a super complex case once a month. And so one of the things is, and I think the point has been made, is that we're kind of on a pendulum. We went from value-based, we went all the way, or we went from volumes to value, and now we need to come back a little bit to the center to allow for some of the positive aspects that a volume-based system had, and being able to give people a diversity of experiences that they have throughout their workday.
That's so interesting in light of the continuous rhetoric around, like, heart surgeries only go well if heart surgeons do a billion over and over. And that is just thinking about the outcome of the heart surgery. Brandy, I want to give you a chance to comment on how can we be advocates and effective experienced designers up and down organizations and across, because I know you had great thoughts and you were mentioning earlier, how can we be better collaborators with data scientists and the like?
Yeah. Well, I mean, I think that's one of the benefits, I think, of working. I think that's one of the benefits that clients that we work with see from working with a company like IDEO or other design companies that they could work with, is that we are outsiders inherently into the system. So we are relatively unbiased. We're taking into account the different needs of the organization, but we're also listening with open ears to all of the stakeholders. And so I think that I guess other than what I've already said, I guess that's one of the other things that I would add, is just that I think that to some degree it's really hard to be outside the system, right? It's as an individual doctor or as an individual nurse or even as a group, it can be really difficult to have these conversations as an organization. And so some of that change needs to happen at an organizational level. And I think it's about making sure that the right people are in these conversations to create change and to be open to systems of change that might open more doors. And so I think that can be a benefit of working with an outside organization. As much as that often happens, I'm like, Allison, that's something that you're doing every day as well, as kind of serving in that role. But in addition to that, I think having some sort of role either within your organization or outside of your organization, that whose job it is to talk across those different stakeholders and to really make sure that the decision makers in any given system are bought into the idea that something needs to change, right? And so a lot of that is about data, but it's also about storytelling and telling the story of why something needs to change, why we need to try something new. And so I think that an outside lens can really help in telling that story and collecting those stories from everyone, because oftentimes it can be tricky to really get honest answers from all of the parties as well.
And I think your point about storytelling is great. And I think oftentimes everybody would like to move in this direction. This is not something that's wildly controversial and people are like, no, I don't want people to be well and I don't want to bring value to the system. It's about how do you craft the story to make it compelling enough to really to support institutional change and policy change. It's really about how do you develop the narrative around it to get some momentum going.
Yeah, absolutely.
Fantastic point. Before we transition to audience Q&As, and audience, that is your cue to start thinking of great questions and throwing them into the chat. I'll be filtering through them for the panelists. But while audience members are thinking through that, I want to end on a hopeful note. We've explored a lot of real experience-grounded reasons to question the hype around value-based care, real reasons to get excited about it, but thinking towards the future of experience design in value-based care, what are you hopeful for?
I'm just excited that the ongoing shift in mindset that I see with our providers and what they deem success to be. it's really exciting for them to say, you know, like, I can't do this thing that I was probably expected to do 10 years ago, but I'm very happy with the work that I've done. So it has really shifted how people argue or articulate what success is in a healthcare encounter. So I'm very excited about that.
I think it's always foolish to be excited about technology in healthcare because it often creates more problems than solutions. So this is qualified optimism. But I do think some of the new tools that use artificial intelligence to help streamline some of the tasks that we have to do address a lot of the challenges that we've articulated across this panel. I've experimented with some of the tools for ambient listening that will, AI scribes. And I think a lot of those, I think, can be pretty transformative in the sense that they allow you to refocus on what matters, getting back to our conversation about measuring what matters, spending less time looking at a computer, spending more time actually, looking at your patient and investing in that relationship. And so I think I'm pretty excited about that. At the same time, it may also help capture aspects of an office visit between a patient and clinician that you can't find in insurance claims data or in EHR data, but things that more closely approximate the value of that relationship or how the quality of that encounter. Was the patient listened to? Were they validated? Was there kind of compassion and closeness between those people? And I think that can bring back a lot of what motivates clinicians to do our job, while also continuing to make sure we're documenting appropriately, measuring what matters, and helping meet what should continue to be accountability around validated quality metrics.
Yeah. And there are several things that make me hopeful, but one is just hearing you talk about that. It's reminding me that I think one thing that I'm hopeful about is that I see more and more physicians actually participating in design and in experience design, either stepping entirely out of the system or dedicating part of their time to working with either companies that are developing new technologies or working within their design systems in a role that's more about experience design. So I've seen a lot more physicians taking an interest in design and the power of design, and I think and collaborating with companies like IDEO and others. And so I think that is really powerful to have that level of expertise, but then also being able to step back and look at it from an experience perspective. So I think that we'll see some really interesting things happening as a result of disgruntlement, largely, maybe. But
it's got to get worse before it gets better.
if that's what it takes to break down the silos, that's okay.
Yeah.
I'm hopeful that people are so angry that they're going to do something about it. That's fantastic. Wonderful. And thank you to everyone who's DMing questions in. Totally fine if people are more comfortable doing direct messages, but also chat to everyone is appropriate. A couple came in circling around, right after we talked about what makes us hopeful, circling around, Sue asked what you were saying earlier around a lot of the levers to pull are path dependent. And to Allison, what you were saying is it's not like anyone is saying, no, I want a horrible experience, but even opportunities that we can see with value-based care specifically rely on levers that have been so predetermined decades ago. How do you guys think about designing in an environment that has already been so defined from decades and decades of decisions that are hard to peel back now that we're here?
One small thing I'll say is just that I think in a lot of ways design loves constraints, and so I think design can be great to reimagine a system entirely. But I think one of the things that design is great at is saying these are the conditions that we exist in. This is the system that we exist in. So how can we design within these constraints? And getting creative within those particular constraints is one of the real powers of design, I think. And so I guess that's a short answer, but I think that there are always opportunities to redesign within constraints. And so I think looking for those is something that we can certainly do.
I completely agree, and I love a good constraint as a designer. And I also think, kind of back to one of my earlier comments, is that we need to be really clear about the role of healthcare in health and well-being of individuals. A lot of the work that we do, and we did some great work early on where, we wanted to be able to write a prescription for someone for food or for transportation, but in a lot of ways, while we can help make a connection, that really shouldn't and isn't the role of healthcare. And so how can we set it up so that we have stronger partnerships, and that the levers are something that we empower our patients to either be able to make or have more capacity to make, because one of the things that we find is that we can't do certain things because the other levers are just not even pullable.
Allison, I just want to underscore that point. I think, I agree intuitively with, the crucial importance of social determinants of health to our patients, and I know we all do. At the same time, I've sometimes wondered whether so much of the investment in those initiatives comes at the cost of, one, to your point, bridges to nowhere, right? Where there's so much we can't control, and doing referrals that end up not getting fulfilled. But then two, trying to fix things that we have that are outside of our locus of control, while neglecting to fix the things that are within our locus of control, right? There's so much we need to fix, so much of the experience, that we've discussed today that needs to be rethought. And I think a lot of our focus, as we've discussed today, should be on those things. And we can't afford to split our focus, so to speak.
Very insightful. Another question coming in goes back to something you were saying, Allison, earlier, is when we use phrases like quality of experience or just designing of an experience, to be really careful to not conflate that with, Disney, like Disneyland or travel or these other experiences. Their question is, how should we think about designing experiences? I'll add to their question, high quality, high value in the lens of value-based care experiences that are just inherently not going to be good. So think about loss, think about change. How can we think about experience design?
Yeah, that's a great question. That's a fantastic question. And I think it's something that when people initially come to design in healthcare, they don't realize that it's going to smack them in their face pretty darn fast. But one of the things I think, and I think it goes back to something that Suha said earlier, is this is really all about developing and building relationships, and having these relational aspects of healthcare to be supportive. And so even though you're going through a terrible experience, you may feel very supported, and you may feel very understood. I worked with a nurse in the hospital who was supporting a patient who was having significant pain, and they were able to get them some pain medication, but it wasn't going to kick in for about 20 minutes. And the nurse said, "I'm going to do nothing else but just sit here and talk to you. We're going to talk." And he goes, "We're going to talk about my garden, and I hope you like gardens, because that is what we're going to talk about right now." And just worked through it. And, we're all crying, and it's this amazing experience. And it really is about relationships. And so I think one of the other questions that kind of came in too is, about like AI and data and digital technologies. One of the things that we've said in the project that I'm working on now is that anytime we introduce a digital technology or AI or anything like that, it has to be to prioritize the relationship. It may improve our volumes and our efficiency and our quality, the whole point of it is to allow for the relational aspect of healthcare to be prioritized at all times. And so the person feels understood, the person feels heard, and the person feels taken care of. And that can happen whether or not you're being cured of cancer or you're being told that the experience that you're having is one that's going to be terminal. I think the other thing too is that you have to be able to modulate your processes based on where someone is within an experience. Right now, in most clinics, if you walk into an appointment, the way you walk in and the way you walk out will be exactly the same if they're going to tell you that you're having a curative journey or if they're going to tell you that unfortunately there's nothing else that they can do for you. There aren't a lot of processes in place that change what that looks like. And so I think we really need to figure out how we can make these micro adjustments to experience over time in everyone's journey to really accommodate where they are in terms of their knowledge of what's going on, their experience with the healthcare system, their comfort with what they're dealing with, who's with them. There are a lot of different factors. And so at that point, when you're really designing towards a really nuanced level of tuning things to meet the patient where they are, it doesn't matter as much if it's a good experience or a bad experience in terms of, is it what types of news we're trying to deliver? It really is more about how do we meet the patient where they are in terms of relationship.
I love that. I just want to emphasize, the relationship sort of being kind of the North Star of whatever new technologies or experience changes that we're trying to introduce. You could imagine, in contrast, a situation where AI scribes were brought in to a clinic and thereby reducing the amount of time that a clinician needs to spend on documentation, and that time instead being repurposed towards more visits, right? Adding another 2 office visits per day into the schedule, and that gets helps the volume and looks at those other metrics, but doesn't. But then you would fail to get the full benefit of that intervention, right? Which is freeing up that cognitive load, trying to address burnout, refocusing time on relationships, and so I think being very clear-eyed about what the North Star of these interventions is critical, and also having leadership that agrees with that and wouldn't take the time that's liberated from one important change and then repurpose it towards something that makes the net effect null or even counterproductive.
Yeah, I think it's especially challenging too when these tricky moments lead people outside of the system. I'm just thinking about there are moments within a hospital experience where at some point what someone's going through, essentially from the hospital's perspective, becomes not their problem, unfortunately. So I'm thinking of experiences where someone transitions to hospice. Oftentimes the patient is sort of, if that system is not offering hospice themselves, then the patient is sort of left to understand and uncover what comes next for me and my loved one in hospice. And essentially the experience at that point is, well, we don't know, good luck figuring it out. Here's a list of resources, right? And so I think that one of the things that I see happening is companies coming in to fill in the gaps, services that are being offered to step up, and whether it's a technology startup or something else, are really stepping up to fill in some of those gaps. And I think that a lot could be learned from that, and a lot of those services that are popping up, whether they will last in the long term or not. I think that the hospital systems could learn a lot from them and think about incorporating some of what they're doing within their systems as well.
Makes a lot of sense. And our last question is my own question, though we have a lot. Thank you everyone who's been DMing me questions, a high level of thought going on in the audience, but I will selfishly take the last one. What has the audience not asked or I not asked that you wish we were thinking about in terms of experience design and value-based healthcare?
clearly a really challenging question.
In your defense, I gave you no heads up.
I think we covered a lot, though. I
We
think
did.
really, while all three of us recognize, and I don't at all mean to speak for anyone else, but we recognize that there are both benefits and limitations to value-based care. I think carefully analyzing it from a design-based perspective allows us to take what's good from it and continue to build upon it, and then kind of comfortably let go of the things that we thought on the surface level would be very successful, but ended up being the system is just simply so complex. And I think because the system is so complex, that's what really allows design to be something that gives you an approach that is nimble and exciting for when you're trying to make improvements. So kind of a roundabout non-answer, but there you go.
No.
I'll just say that I really loved hearing about the experimentation that Allison was discussing, and I'm sure Brandy implements similar methods in her work. I think just approaching change to clinical workflows with humility and from a place of curiosity, I think is so helpful. And then being rigorous about how we pilot, deploy, and then test the impact of interventions, with the outcome metrics being the things that really matter. Back to our conversation about measurement, I think that's really the path forward. And I think it's so exciting to hear that very large health systems are thinking about it this way. And I think that will help us not repeat some of the same mistakes that have been repeated in the last 10 to 15 years, where so much measurement, proliferation, et cetera, other things we talked about that have actually deteriorated the experience. We can, over the next 15 years, make sure we make it improve the experience.
I think just to build on that for a second, and I'm sorry, Brandy, but inherently within healthcare, one of the best things is that people are in it to help people. And so they're really, and I have to remind myself of this sometimes, there aren't really any bad actors. It's just people who are incentivized to act in a way that seems at odds with what we're trying to do. And so Suhas, I think to your point, like just trying things and coming at it with curiosity to be like, why are you acting this way? Because I know we agree that we're trying to help patients here is just an incredibly valuable mindset that you have to kind of constantly remind yourself of.
Yeah, I love that. And I guess one of the things on my mind that we haven't talked about yet is I think that one of the interesting things about healthcare is that, unlike a lot of other experiences that we encounter as people, there hasn't necessarily always been thought put into an intentional design put into the front end of the experience for a patient within a system. And I think that a lot of times we change things on the back end, and then we just expose that back end to patients and providers. And so the back end is just there hanging out, and patients and providers are like, wait, what just happened? And I think that thinking about and coming at it from a perspective of how do we actually intentionally design a front end of this experience for patients and providers is just something that isn't always thought of. And so I think finding those moments to design that front end and what that should feel like, we don't even necessarily have to always change the back end, right? The back end can stay exactly how we need the back end to stay. And the front end can really do a lot. And so even if we don't change how something actually works, just thinking about how then patients and providers have to then interact with that reality can go a long way. And so that's also a hope as well, as just that I think it doesn't necessarily always mean that the entire system needs to change. The little tweaks in how news is delivered or in how a patient receives information, little things like that can go a long way. For both patients and providers. And so I guess I would leave it at that. And yeah, I've also really enjoyed hearing from Allison and Suhas today on their experiences.
Fantastic note to end on. Thank you, Brandy. Thank you, Allison. Thank you, Suhas. The depth and breadth of your experience really made this conversation what it was. Thank you to all the great questions that came in and for tuning in. Stay in the loop for future Boston chapter events coming up. Won't all be healthcare related, despite my best efforts, but really exploring service design role in other complex systems as well as some in-person meetups on the horizon. That being said, we are at time. Thank you, panelists. Thank you, audience, and looking forward to everyone integrating what they learned in their work this week.